Good morning, everyone, and welcome to Grand Rounds. I have the pleasure of introducing Dr. Hooman. He received his undergraduate degree from Dartmouth College, majoring in physical chemistry and mathematics. He obtained his medical degree at Columbia University and then completed his internal medicine and pulmonary and critical care training also at Columbia. Since 2013, he has been on faculty at Mount Sinai with appointments in both the Division of Pulmonary and the Division of Cardiology as an associate professor of medicine. His clinical responsibilities range from attending in the MICU to seeing patients in pulmonary hypertension clinic. He is also the director of pulmonary vascular disease of Mount Sinai National Jewish Health Respiratory Institute, and he founded the multidisciplinary pulmonary embolism response team at Mount Sinai. At the beginning of the pandemic, he was one of the first to appreciate the pulmonary vascular effects of COVID-19, both with respect to pulmonary thrombosis and pulmonary vasodilation. He is also dedicated to medical education, having received multiple teaching awards, including the Solomon Burson Award, given to a faculty member who has made the most significant contribution to house staff education. Additionally, he is the course director for the pulmonary pathophysiology course for the second-year medical students and has published a textbook entitled Basics of Mechanical Ventilation. Please join me in welcoming Dr. Pour for Grand Rounds.
Good morning, everybody. Thank you for inviting me to talk about pulmonary hypertension. So these are my disclosures. Consulting for United Therapeutics. So I'm going to start with a case. You're in your clinic. You see a 39-year-old woman who presents with a year of worsening dyspnea on exertion. She's short of breath after walking about half a block. An echocardiogram is performed. She has normal LV function and size. Her EF is 75%. Her RV is severely dilated and dysfunctional. And she has an estimated RBSP of 90. So the question is, what do? Do you do nothing? The LV is fine and that's all that matters. Do you prescribe a calcium channel blocker? Start with this class of medications first to see if it works. Do you refer her to hospice? She has end-stage disease and there's nothing else that can be offered. Do you hide in the bathroom? PH patients are hemodynamically tenuous and will code if you glance at them the wrong way. Or do you begin the workup to better characterize her pulmonary hypertension? So I say A through D somewhat in jest, but in all seriousness, I've seen kind of variations of this. And the hope is that after this talk, we can get to E. Specifically, I'm going to talk about the physiology of the pulmonary circulation, how we classify pulmonary hypertension, the pathophysiology of PH, the vicious cycle of RV failure, and the treatment of PH. So the pulmonary circulation is characterized as a low pressure circuit. So here's a Netter diagram. You can see that the systemic circulation, we have a mean arterial pressure of about 93. By the time we get to the capillary bed, much of that has dissipated down to about 30. And when we get back to the right atrium, we have a right atrial pressure of 2. A normal mean PA pressure is about 14. Very little of that pressure dissipates by the time you get to the capillary bed. We come back to a left atrial pressure of about 5. And so to understand these hemodynamics, we go back to high school physics with Ohm's law, where a voltage difference across a resistor is equal to the current of electrons times the resistance. And we can apply this to the circulation, except instead of a voltage difference, we have a pressure difference. Instead of a flow of electrons, we have a flow of blood, which is the cardiac output, and the resistance here is the pulmonary vascular resistance. The pressure difference that we're looking at is the pressure difference between the pulmonary artery and the left atrial pressure. And so when we rearrange the equation, we now have the PA pressure is equal to the cardiac output times the pulmonary vascular resistance plus the left atrial pressure. Note you can do the same exact thing for the systemic circulation, except we have the systemic pressure, the systemic vascular resistance, and the downstream pressure is the right atrial pressure. So given that the cardiac outputs are basically the same, as long as you don't have any weird shunts, the left and right atrial pressures are both low and about the same, then the reason that the pulmonary pressures are so much lower than the systemic pressures is because pulmonary vascular resistance is much lower. And that really is the hallmark of the pulmonary circulation, is that it's a low resistance, high compliance circuit. And the pulmonary vessels have much less muscle and elastin than the systemic vessels. And there's also this concept of capillary recruitment. So many of your capillaries are compressed at rest, and when you exercise and you walk, more blood flows through them, and they actually dilate. And when they dilate, the cross-sectional area of those vessels goes up, and therefore the resistance goes down. So the definition of pulmonary hypertension is a mean pulmonary artery pressure of greater than 20 at rest, as measured by a right heart catheterization. It used to be defined as a mean PA pressure greater than 25. And that was done away with after a meta-analysis done by Kovacs. There were 47 studies from 13 countries. It was about 1,200 asymptomatic individuals, so patients without any symptoms who underwent right heart catheterizations. And the average mean PA pressure was 14 with a standard deviation of 3. So you take 2 standard deviations above the mean, and now you have 20. This also has important implications by a study done by Bradley Marin, done in the VA, about 20,000 right heart catheterizations in the VA population, and they looked at mortality. And when many covariates were controlled for, you can see that there's a correlation between mean PA pressure and mortality. However, that correlation really begins right after a mean PA pressure of 20. So something happens above a mean PA pressure of 19 where this pressure elevation is of clinical significance. So how do we classify it? Previously, we used to classify it as primary versus secondary pulmonary hypertension. I really advocate we don't use this. And this classification was changed because of the World Health Organization, the World Symposium on Pulmonary Hypertension. The first one was held in Geneva in 1973. It occurred because of this increased rate of, at the time, called primary pulmonary hypertension, secondary to weight loss drugs like Aminorex. And then the next one was held in Evian, France in 1998. This is where the main framework for our current classification was developed. 5 years later in Venice, 5 years later in Dana Point, then in Nice, and then in Nice. The reason why I show this particularly to trainees is that when you're thinking about the specialty you're going into, it's really important to know where your conferences are held. The next one actually is this summer in Barcelona, so it's not too late to get into pulmonary hypertension. So what are the causes of pulmonary hypertension? So remember that the definition is a mean PA pressure greater than 20. So here's our equation. If the definition is a high PA pressure, then it's either because you have an increase in cardiac output, an increase in pulmonary vascular resistance, an increase in left atrial pressure, or some combination of the three. And so with respect to increased cardiac output, this can occur if you have a left to right shunt from a congenital heart defect like an ASD or VSD, high output states like cirrhosis or anemia, AV malformations, AV fistulas. We had a crazy case of thiamine deficiency a number of years ago. You can have increase in left atrial pressure. This is your run-of-the-mill left heart failure, whether it's systolic or diastolic failure, mitral or aortic valve disease, whether it's stenosis or regurgitation, restrictive cardiomyopathy. And the increase in pulmonary vascular resistance comes in different flavors. You can have destruction or obliteration of the pulmonary vascular bed, say in interstitial lung disease or emphysema, or you can just occlude it with pulmonary embolism. Hypoxia is a very strong stimulus for pulmonary vasoconstriction. So either in a disease state like COPD, or if the ambient air has low in oxygen, like high altitude. And then there's a very specific small pulmonary arterial vasculopathy, which we call PAH. And so this is the WHO classification, groups 1, 2, 3, 4, 5. Group 1 is an increase in pulmonary vascular resistance, secondary to these causes, and it's a primary vasculopathy, so it's really just the blood vessels of the lungs. Group 2 is where we have left heart disease causing an increase in left atrial pressure. Group 3 is an increase in pulmonary vascular resistance secondary to other lung diseases like COPD and ILD, et cetera. Group 4 is an increase in pulmonary vascular resistance secondary to large artery obstructions, the main one being chronic thromboembolic pulmonary hypertension, basically clots that don't go away. And group 5 is everything we couldn't fit into groups 1 through 4. And so the reason why primary versus secondary isn't that helpful is because if I were to tell you that a patient has pulmonary hypertension secondary to scleroderma, well, scleroderma can cause this primary vasculopathy in group 1 physiology. Scleroderma can cause cardiac fibrosis and left heart disease. Scleroderma can cause pulmonary fibrosis and lung disease. Scleroderma puts you at increased risk for blood clots and therefore potentially, CTEPH. So secondary to scleroderma is not nearly as helpful as understanding the underlying pathophysiology. And so primary is really this tiny sliver of patients here, and secondary would be everything else. I kind of joke around that it's primary versus secondary is analogous to taking everyone in the United States and splitting them up into those who are named Hooman and not Hooman. This is a more helpful kind of framework. Because the vast majority of patients really have pulmonary hypertension, secondary left heart disease, and lung disease. So a few hemodynamic definitions. PAH and pH are not the same thing. pH is merely a mean PA pressure greater than 20, as measured by right heart catheterization. PAH is a subset of pH. Specifically, it's a mean PA pressure greater than 20, but you have a pulmonary capillary wedge pressure less than 15, and a pulmonary vascular resistance greater than 2. It's important to note that group 3, which is the lung disease pulmonary hypertension, and group 4, which is the large artery obstructions, have exactly the same hemodynamic signature as group 1. So you can't tell the difference between them in a cath lab. So the exercise criteria is no longer part of this definition. Previously, a mean PA pressure greater than 30 with exercise was deemed to be pulmonary hypertension. And again, going back to Kovacs's paper, he found that during slight exercise in patients who are completely asymptomatic, greater than 50% of patients older than 50 years old had a mean PA pressure greater than 30. So if you have people who are asymptomatic and half of them develop exercise-induced PH, it's probably not a disease, at least in the way that it's defined. And you can imagine if you have this equation, if you increase cardiac output with exercise, that should result in the PA pressure to rise. However, when that happens, the pulmonary vascular resistance goes down with exercise because your vessels dilate. So that's why it's mitigated. So what happens with PAH? This is a normal pulmonary artery. We have these 3 layers. The tunica intima is where you have the endothelial cells, the tunica media with the smooth muscle cells, and then the adventitial layer here with collagen fibers and fibroblasts. And lesions that occur in PAH are fibrotic and proliferative lesions in the small muscular arteries. These are less than 500 microns in diameter. We have active vasoconstriction, so we actually get squeezing of the vessels. We get arterial remodeling in all layers. So you see the tunica intima is thickened and fibrotic. The smooth muscle layer here becomes hypertrophied, and then also the adventitial layer, and we'll have inflammatory changes as well. There's this very weird lesion known as plexiform lesions. This is where endothelial cells kind of like break off and occlude the vessels. Again, it's really kind of the hallmark of this proliferative aspect that's going on. And then we also have in situ thrombosis. So you can see here that these are kind of long-standing changes that occur resulting in increased pulmonary vascular resistance. And the pathogenesis involves at least kind of this trinity of pathways here. We have the endothelin pathway. Endothelin results in vasoconstriction and proliferation of smooth muscle cells. This pathway is upregulated. Nitric oxide results in increased cyclic GMP. Cyclic GMP is vasodilatory and antiproliferative. This pathway is downregulated in the disease. And prostacyclin results in increased cyclic AMP, which is vasodilatory and antiproliferative. This pathway is downregulated. So within group 1, PAH, we can subclassify them into idiopathic. We have heritable. Within heritable, the most common mutation is a mutation in the bone morphogenetic protein receptor 2. 70% of those who have heritable PAH have this mutation. However, only 20% of people with the mutation actually develop the condition. There's drug and toxin induced, dasatinib, anorexogens like fen-phen, Eminerex, and illicits. So the main illicit now really is methamphetamine, so crystal meth is a big deal, particularly on the West Coast. And then we have PAH associated with other diseases, the big one being connective tissue diseases like scleroderma and lupus, congenital heart disease. So if we have an ASD or VSD and we have blood going from the left side of the heart to the right side of the heart, that results in increased flow and pressure in the pulmonary vasculature. And over time, that increased flow and pressure will damage the vasculature and give you those changes of PAH. Portal hypertension, the liver seems to detoxify certain evil humors. When it's not working and bypasses it, you then get damage to the vasculature and PAH. HIV, and worldwide schistosomiasis is a major cause. So PAH is not that common. The prevalence is estimated to be about 15 to 50 cases per 1 million adults. But within different populations, the prevalence can vary. In scleroderma, it's about 10 to 15% will have group 1 PAH. Portal hypertension, estimated about 2 to 16%. And in congenital heart disease, for those who have an ASD that's unrepaired, about 10%. And those who have a VSD, so larger, about 50%. It's a deadly disease. The median survival of untreated idiopathic PAH is 2.8 years. Survival is 34% at 5 years, untreated. However, it depends on the underlying condition as to what the prognosis is. So you can see here that congenital heart disease has the best prognosis, collagen vascular disease has very poor prognosis, and idiopathic is straight in the middle there. If you take someone with limited scleroderma who doesn't have PAH, you have like a 5-year survival of about 80%. However, if you have PAH, survival plummets below 20%. So particularly in certain conditions, it can be a major cause of mortality and morbidity. So the underlying issue is a primary vasculopathy. However, patients ultimately succumb to right ventricular failure. And that's how this disease progresses. And so the question is, why is there such a difference in prognosis between systemic hypertension and pulmonary hypertension? You've seen plenty of patients in your clinic who have systemic hypertension. They don't run out screaming that they have a median survival of 2.8 years. And it has to do with the ventricles, your left and right ventricles. And classically, the right ventricle has been viewed as a weak version of your left ventricle, but this is not the complete story. They're embryologically different. The RV and LV myocardium arise from different origins, and they're structurally different. So the LV here is concentric shape. The RV is crescentic shape. The LV free wall is much thicker, about 8 to 11 millimeters, whereas the RV free wall is much thinner. And then the LV has these circumferential fibers that go around in a circle that provide the majority of the force of ejection. The RV lacks these fibers and instead depends on these longitudinal fibers. They're functionally different. The RV is much more compliant. It's like a floppy balloon. And the RV myocardial energy expenditure is much less, about 1/5 of that of the LV. And so if we go back to first-year medical school, this is the pressure-volume relationships of the LV. This is where the mitral valve opens, and during diastole, blood fills the left ventricle. The mitral valve then closes when the LV starts contracting, and we get this clear period of what's called isovolemic contraction, meaning that the LV is contracting, the pressure is rising, however, no blood is ejecting. Until the aortic valve opens, blood is ejected, and then the aortic valve closes during diastole, and we have a clear period of what's called isovolemic relaxation, meaning that the pressure is going down, the LV is relaxing, but no blood is coming in or leaving. So what does the RV look like? The RV looks like this, where there are no clear periods of isovolemic contraction or relaxation. During systole, blood is being ejected. During diastole, blood is being ejected. And so it doesn't require the chamber pressure to go up and then to open. It can start pumping out blood immediately. This is a much more efficient system. And so the main question here is, are these characteristics of the LV and the RV specific to the ventricles, or do they have anything to do with the circulation that they're pumping into? So why don't we take an RV and increase its afterload and see how that acts? And so, for example, in the setting of pulmonic stenosis, an RV looks shockingly similar to that of a normal LV, where you have clear periods of isovolemic contraction and isovolemic relaxation. What if we take an LV and decrease its afterload, for example, after a mustard repair? So the LV is now pumping into the pulmonary circulation, the RV is pumping into the systemic circulation. So the RV is pumping, and the LV is pumping into a low pressure circuit, and it now shockingly looks like a normal RV. And the point of this is that the functioning and the performance of these ventricles is heavily dependent on the circulation that they're pumping into. And so that brings us to how a pump works. So if we have a tube of blood with blood flowing through it, or any kind of fluid, and we place a pump, the way a pump works is that it increases the flow through here. And when that happens, it reduces the pressure before the pump and increases the pressure after the pump. I have a lot of appreciation for pumps because my basement has flooded like 4 times this year. But this is how a pump works. And so if our pump is the right ventricle, we have the pulmonary arteries in front of the pump, and we have the systemic veins after the pump. The pulmonary arteries after the pump and the systemic veins before the pump. And so if we induce RV failure, we now have a decrease in the flow through these tubes, and this results in decreased perfusion of our organs. We get dyspnea, chest pain, lightheadedness, and syncope. And because this pump isn't working, this pressure goes down and this pressure goes up. This increase in pressure here results in increased venous congestion that gives us lower extremity edema and ascites. And so the main question had been previously, is RV failure occurring, these signs of ascites and lower extremity edema, because of intrinsic problems in the RV? And so in the 50s, animal preparations were taken where they would literally try to obliterate the right ventricle. So in this experiment here, a red hot soldering iron was laid repeatedly all over the surface of the right ventricle. And after the right ventricular wall had been attacked repeatedly with a cautery, only minimal changes of venous pressure followed the most extensive damage to the right side of the heart that we knew how to inflict. So besides these authors requiring some anger management courses, the point of this is that they were not able to induce RV failure merely by kind of charring this right ventricle. And shockingly, this experiment was repeated multiple times in many different ways. And in this experiment by Bakos, they demonstrated that the pulmonary pressures did not drop, that the pump was still somehow working, and that an actively functioning right ventricle is therefore not absolutely necessary for the maintenance of a normal pressure gradient in the pulmonary arterial tree. And so this was taken a number of steps further by Damiano, because the concern was like, well, maybe there's still some right ventricle that was still working. And in this case, they did a full thickness ventriculotomy. They literally just cut the whole thing in half and then re-sewed it together. And the reason to do this was to electrically isolate the right ventricle. And they placed some electrodes in the right atrium, the left ventricle, and the right ventricle. And then they placed pressure probes and a flow probe to see how much blood was coming out. And in this situation, when you stimulated the right atrium, it would depolarize the right atrium, and it would result in depolarization of the left ventricle. However, because the right ventricle is electrically isolated, the right ventricle would not depolarize. And the only way you could depolarize the right ventricle would be to independently depolarize it with the right ventricular electrode. And so here you can see they're depolarizing the right atrium, which results in depolarization of the left ventricle. And independently, they're depolarizing the right ventricle, resulting in pressure generation in the LV, RV, and flow coming out of the pulmonary artery. They continue depolarizing the right atrium, resulting in the depolarization of the left ventricle. However, they then silence the right ventricular electrode. And interestingly, you still have significant pressure generation in the LV and significant pressure generation in the RV, with still lots of flow coming out of the pulmonary artery. And the amount is greater than 65% of that which was originally achieved, despite the right ventricle being electrically silent. Again, a couple steps further, with Hooman, they took an animal preparation and literally just lopped off the right ventricle. And then they placed non-contractile bovine pericardium, so this thing cannot contract. And they were able to demonstrate that the right ventricular pressures would go up and that flow would come out of the pulmonary artery. And they placed this clamp to basically approximate the size of the right ventricle. There are patients that we have who literally don't have right ventricles. These are patients with complex congenital heart disease who've undergone Fontan procedures, where the pressure needed to get to the left side of the heart is generated because of the venous pressures here. So the IVC and the SVC are literally just hooked up to the pulmonary arteries, and there's no pump. And these patients are living many, 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 many years. So literally, they don't have right ventricles. Which begs the question, if you can char the right ventricle and electrically isolate it and lop it off and don't even really have it, if you don't really, quote unquote, need this right ventricle, how do we have patients who end up in our ICU with right ventricular failure? And so the answer is that a functioning right ventricle is crucial for the proper circulation in the setting of increased right ventricular afterload. So afterload is defined as impedance during right ventricular ejection. It's also defined as wall stress during ventricular ejection. The way we increase right ventricular afterload is either increasing pulmonary vascular resistance, decreasing pulmonary vascular compliance, or increasing the downstream pressure, which is the left atrial pressure. And so the left ventricle, a normal left ventricle, is very tolerant of increases in afterload. If you take the aorta and clamp it a little bit to increase the pressure, the stroke volume goes down only a little bit. It's developed to be able to tolerate this increases in afterload. You do the same thing for the right ventricle just fails. Stroke volume plummets. There's also this concept of intraventricular dependence. The right ventricle and left ventricle are two roommates in a small New York City apartment, known as the pericardium. When the right ventricle dilates, it does so at the expense of the LV, and it smushes the LV, does not allow it to fill. And so why is there such rapid decompensation of these patients? We have these PH patients that are out in the community doing well. All of a sudden they get an infection, a bleed, an arrhythmia, stub their toe, anything, and they end up in the ICU on vasopressors and so on. And so this has to do with what I call the vicious cycle of RV failure. Here's a picture of a failing RV. And so it all begins with an increase in RV afterload. That's the hallmark of pulmonary hypertension. And as I showed, an increase in RV afterload results in a decrease in RV output. The RV is what fills the LV, and that leads to a decrease in LV preload. When we have decreased LV preload, the LV output goes down. When the RV afterload goes up, the wall stress on the RV goes up. That's part of the definition. And if there's more wall stress on the RV, and therefore more demand, this will result in increased RV ischemia. And ischemic RV cannot pump out more blood. The RV is like a floppy balloon. When the afterload goes up, it dilates. And remember from Laplace's law, when the radius goes up, the wall stress goes up. Your tricuspid valve collapses like this. When the RV dilates, it gets pulled apart, and you get TR. And that results in decreased RV output, at least forwards. When the RV dilates, it does so at the expense of the LV, and it smushes the LV and doesn't allow it to fill and decreases LV preload. Additionally, that change in the LV structure results in independently kind of decreased contractility and therefore decreased LV output. Part of your LV output is your coronary circulation, and in this case, your RCA blood flow goes down, resulting in more ischemia. When your LV output obviously goes down, and the result of this is this cardiogenic shock, and that's bad. So there are things that we do in the hospital that can bring about the demise of patients with PH that we think are therapeutic for other patients. These include, significant amounts of fluid administration, which will result in increased RV dilation and, throw these patients off the cliff. Additionally, when we intubate these patients and give them vasoactive therapies to induce them, this causes vasodilation of, say, their blood to their skin and their knees, and that will steal blood and result in kind of throwing them off the cliff. So right heart catheterization is a central component of diagnosing and kind of characterizing PH. We're able to measure all of these pressures, the RA, RV, PA, and the pulmonary capillary wedge pressure, that got shifted over, is a surrogate for the left atrial pressure. We measure cardiac output, and then based on this equation, since we've measured everything, we calculate what the pulmonary vascular resistance is. So our treatment goals for a patient with PAH are twofold. The first is to make them feel better. They're short of breath, they can't do as much. We want them to be able to do more activities and ultimately feel better. And the second is to reduce the risk of bad things happening, meaning we don't want them to get hospitalized, we don't want them to die or require a lung transplant, et cetera. And so when it comes to the second component, there are a number of risk factors associated with patients getting worse. They include being male, having comorbid conditions like systemic scleroderma, rapid progression in their disease, signs of heart failure, poor functional capacity, they can't walk as far, whether that's measured subjectively with the WHO functional class or more objectively with a 6-minute walk test or a cardiopulmonary exercise test. Findings on echocardiogram, specifically of the right ventricle. Is the right atrium dilated? Is the right ventricle dysfunctional? A large pericardial effusion is very significant. Markers of strain on the right side of the heart as measured by the BNP, and then certain right heart catheterization findings. And so when we have patients with markedly elevated risk, we give them more aggressive therapy in terms of their PAH, and they will tolerate side effects and logistical issues more because their risk is much higher. For those who are lower risk, we kind of get away with less aggressive therapy. There are a number of risk scores that are out there. One of the main ones that's used is known as the REVEAL risk score that was actually developed by our own Dr. Raymond Benza, who's in the Division of Cardiology. So with respect to the right heart catheterization findings, I ask you a question. Which hemodynamic parameter does not correlate with survival in patients with pulmonary arterial hypertension? Is it the pulmonary vascular resistance, the right atrial pressure, mean pulmonary arterial pressure, or cardiac index? I'll give you 5 seconds. Don't all go at once. So the answer is mean pulmonary arterial pressure. And that seems silly because the disease is defined as a mean PA pressure greater than 20, and you would think, if I have more of this disease, wouldn't I be more sick? And this is like the central component of this disease that you need to understand because that's where lots of confusion comes about. So I give you 2 patients, patient A, patient B. Patient A has a PA pressure of 90/25, systolic over diastolic, with a mean of 45. Patient B is 45/20 with a mean of 30. So one would think patient A is clearly sicker than patient B. However, you look at the cardiac index, which is a cardiac output relative to body surface area of patient A, which is normal, 2.5 to 4 is normal, whereas patient B's cardiac index is very low. The right atrial pressure for patient A is normal at 4, patient B is really high at 24. So it turns out patient A is the one in the community walking around and doing fine. Patient B is the one in your ICU who's extremely sick. And understanding this is key. And if we go to kind of the natural history of pulmonary hypertension, let's look at our equation. And for the sake of simplicity, let's remove this left atrial pressure component. With pulmonary arterial hypertension, we have an increasing in pulmonary vascular resistance over time. And if the right side of a heart can kind of tolerate this and maintain cardiac output, then if pulmonary vascular resistance goes up and cardiac output stays the same, then we see our PA pressure rise. And this is the, I don't really realize I have PH phase. As time goes on, pulmonary vascular resistance continues to rise. However, now the right side of the heart's like, I can't really do this. And so cardiac output starts to drop. As a result, when we have a rise in PVR with a decrease in cardiac output, we now have kind of a plateauing of pulmonary pressure. This is the I get short of breath after walking a block kind of phase. As time goes on, pulmonary vascular resistance continues to rise. However, now the right ventricle is like, I really can't do this anymore. Cardiac output plummets, and as a result, we have this paradoxical drop in pulmonary pressure. And so these are the signs of and symptoms of low perfusion because of this low cardiac output. These are the symptoms of congestion. You see the right atrial pressure that goes up like this. And so when our pump stops working, we have a decrease in cardiac output. We have an increase in right atrial pressure. And that's why a change in mean PA pressure isn't as significant if you don't have the other components. Because if I'm sitting here and the mean PA pressure has gotten better, I don't know if I've moved this way or I've moved that way. And this happens very frequently. A patient has a systolic pressure on a cath of 90. They're doing fine in the outpatient community. All of a sudden, they're admitted with syncope, 20 pounds fluid overload, and doing very poorly, and an echo is done with an RVSP of like 50. And they're like, well, the pH has gotten better, when in reality, it's actually gotten worse. And so this is kind of the misnomer, I think, of pulmonary hypertension, because it implies that it's actually the pressure that's the problem. It's really not the pressure that's the problem. So I say that we change the name of pulmonary hypertension to elevated right ventricular impedance syndrome, or ERVIS, which I've copyrighted, so it's mine. Just kidding, don't use it, seriously. But this has implications for treatment, because in systemic hypertension, the pressure really is the problem. It is the pressure that's actually causing vascular damage, and the goal is to actually reduce the pressure. Whereas in pulmonary hypertension, that's not the case. The goal is really to get the system working better, that there's something in front of the right ventricle, and you need to relieve that obstruction, whatever that is. And so with respect to treatment, we do something called vasoreactivity. This is a highly misunderstood phenomenon. What is done is we administer a short-acting vasodilator like epoprostenol, adenosine, or inhaled nitric oxide. Most commonly, we use inhaled nitric oxide during a right heart catheterization. And a vasoresponder is defined as someone who has a mean PA pressure drop of greater than 10 to an absolute value less than 40 without a concurrent drop in cardiac output. And so again, if we go back to our equation and we remove the left atrial pressure for the sake of convenience here, if we have a drop in PA pressure where the cardiac output doesn't change or goes up, that simply means that the pulmonary vascular resistance is going down within like 2 minutes. And so if you're a vasoresponder, you're more likely to have a sustained beneficial response to calcium channel blockers. And this was just demonstrated by a famous paper by Stu Rich in 1992, where he took patients who had, at the time called primary pulmonary hypertension, but basically idiopathic pulmonary arterial hypertension. He did vasoreactive testing with them. And those who were not vasoreactive did not give them calcium channel blockers. And this is what their survival curve looks like. And these are two historical cohorts as well. So very poor survival. For those who are vasoresponders, he gave them calcium channel blockers, and you can see a markedly better survival here. This doesn't really mean that calcium channel blockers are anything special, but it is kind of defining a phenotype. Because if I give you a short-acting vasodilator, and just like that, your pulmonary vascular resistance almost normalizes, well, let's look at the reasons why your pulmonary vascular resistance is high. Inhaled nitric oxide is not going to obliterate the thrombosis that's there, or this remodeling, or the plexiform lesions. It really is just picking out those who have a vasoconstrictive phenotype, and as such, a drug that just simply vasodilates, like a calcium channel blocker, would be sufficient. It's important to note that only those who are within this small category here are actually vasoresponders, so all the rest are not. And within this trial, only 13% of those patients were actually vasoresponsive. And additional trials have shown that after 1 year, only about half of these patients remain vasoresponsive. So you take a disease state that's about 5 to 15 per million, of which only 13% are vasoresponsive, of which only half remain vasoresponsive after 1 year. We have like a minute patient population that's actually on this. It's interesting from a prognostic standpoint. They do very well, but it's a very, very small population. And in the cath lab, it's actually very jarring. When we give someone nitric oxide, all of a sudden it looks like they're about to have a cardiac arrest because their PA pressure is almost like normalized like that, when in reality it's just, they're vasodilated and all is good. So prior to 1995, we really just had calcium channel blockers for this minute patient population and really nothing else, until 1995, where we had intravenous epoprostenol known as Flolan. So epoprostenol is known as prostacyclin. It's an endogenous substance. It has a very short half-life, about 3 to 5 minutes, and therefore it requires continuous administration with an intravenous pump. This is the original trial. 81 patients over 12 weeks demonstrated a mortality benefit. 8 patients in the placebo group died, whereas no one died in the epoprostenol group. However, this drug is kind of cumbersome. We still think it's like the Cadillac of pH therapy, the nuclear weapons of pH therapy. However, it requires a pump and this Hickman catheter and all the complications associated with it. In the early 2000s, our first oral drug was approved. And since then, we have 13 approved pulmonary vasodilators for PAH, coming in oral, IV, subcutaneous infusions as well, and inhaled. And so they, again, deal with the kind of trinity of pathways. Within the endothelin pathway, we have the endothelin receptor antagonists. These are all oral drugs. Within the nitric oxide pathway, we have the PDE5 inhibitors, sildenafil and tadalafil, prevent the breakdown of cyclic GMP. Riociguat helps the conversion of GTP to cyclic GMP. And then within the prostacyclin pathway, this is probably the most potent, but has the most side effects and the most in terms of logistical issues with 4 times a day inhalations or continuous infusions. We have epoprostenol, treprostinil, which in its intravenous and subcutaneous form is remodeling, which you've seen a lot of. Tyvaso is the inhaled form. Iloprost and selexipag is the oral IP receptor agonist. It's important to note that these drugs are really just approved only for PAH, group 1, not for the others, with the exception of riociguat for chronic thromboembolic pulmonary hypertension, inoperable, and inhaled treprostinil for pulmonary hypertension associated with ILD. And so previously, we used to give kind of one oral drug, see how a patient does for like 6 months or a year, and then if they needed another drug, we would add the other. And it became clear that everyone kind of needed 2 drugs. So then the question is, well, why don't we do both at the same time? And this was the AMBITION trial, where patients who were newly diagnosed with PAH were randomized to tadalafil, which is a PDE5 inhibitor, versus ambrisentan, which is an ERA, versus both combined. And they found that taking both together reduced the rate of kind of bad things happening compared to one or the other. And this ushered in the era of what we call upfront dual oral therapy. The survival, so I had mentioned that there was a median survival of 2.8 years from the NIH registry. And since then, subsequent registries have shown marked improvement in survival, where median survival is around 7 years. However, you can see that these time periods are still way back in the day, and they don't include many of the therapies that we use and many of the treatment strategies. So it is increasing survival, markedly so. A few considerations about pulmonary vasodilator use. Not only do they decrease pulmonary vascular resistance, they also decrease systemic vascular resistance. So you must use them cautiously in those who are hypotensive. Don't just stop the medicine, particularly if they're in continuous infusions. That can result in rebound pulmonary vasoconstriction and catastrophic pulmonary hypertension and RV failure. So you want to gradually wean these therapies. They can lead to worsening ventilation perfusion mismatch and result in hypoxemia. So we have to be cautious in those who have intrinsic lung disease. So if we have our blood flow here and our ventilation here, and if we have an area of the lung that is now not ventilated, say from a mucus plug or fibrosis, the lung is very smart. It will constrict the areas of the lung to that poorly ventilated area and reroute blood to the good areas of the lung. This is known as ventilation perfusion matching. If now we administer a systemically administered pulmonary vasodilator, it will indiscriminately vasodilate all the blood vessels, including the poorly ventilated areas. Blood will go by here, and gas exchange will worsen. One way to circumvent this problem is to deliver the medication inhaled, whereby the medication only gets to areas of the lung that are well ventilated and preferentially vasodilate those areas, which was a rationale for giving inhaled treprostinil for patients with pulmonary hypertension associated with interstitial lung disease. 326 patients randomized to inhaled treprostinil, which is Tyvaso, versus placebo. It resulted in an improvement in 6-minute walk and a decrease in clinical worsening in this short period of time of 16 weeks. It is the only drug approved for pulmonary hypertension associated with ILD. Finally, pulmonary vasodilators can lead to increased pulmonary capillary pressure and result in pulmonary edema. So we have to cautiously use it in those who have increased left atrial pressure. And the idea here is, let's say we have increased pressure on the left side of the heart, therefore there's high pressure in the pulmonary vein, high pressure in the pulmonary capillary. And if we concomitantly have pulmonary vascular resistance issues here, narrowing of the pulmonary arteries, if we now give a pulmonary vasodilator, more blood will flow through here, which will result in increased pulmonary capillary pressure, potentially leading to pulmonary edema and further increases in left atrial pressure, which can then lead to decompensation of the left side. And so in patients with systolic heart failure, intravenous epoprostenol led to increased mortality. They stopped this trial early, and bosentan and endothelin receptor antagonist led to increased CHF exacerbations. So those are kind of our current therapies. And I kind of shift gears a little bit to talk about a famous case report published in 2010. It was about a patient in 1987 who was 31 years old, who at the time was diagnosed with pulmonary arterial hypertension. She had a mean PA pressure of 43. You can see a PVR of about 6.4. Remember, PVR of 2 is normal, below 2. At the time, there were no therapies, so she really wasn't on any pulmonary hypertension meds, and her pressures continued to worsen. Mean PA pressure of 72, cardiac output drops, PVR goes through the roof. She's super short of breath, basically functional class 4. She gets enrolled in the original Flowland trial, the original epoprostenol trial, and is randomized to treatment. She now does much better. She's improving in functional class, PA pressures come down, they don't normalize, pulmonary vascular resistance improves. As you can see through the years, she continues to kind of improve and stabilize and is basically with minimal symptoms on continuous intravenous epoprostenol. And so for a disease that has a median survival of about 2.8 years, she lives 18 years. And the question is, well, what happens to her pulmonary vasculature? Clearly, these medications must be undoing all of these vascular lesions. I mean, if we're going to say remodeling is called remodeling, it's like it's remodeling the vessels, right? It must be, if the pharmaceutical company tells us it's doing it, it has to be happening. And so, but we don't biopsy patients who have pulmonary hypertension because there's no clinical utility in doing that, and there's obviously huge risk. And the only time we see these vessels under a microscope is when they've died, and that's end stage and not that helpful, or when they've gotten a lung transplant, that's end stage and not that helpful. So after 18 years, she develops abdominal pain, is diagnosed with metastatic colon cancer, and ultimately dies. So then she was very in tune with the PH community, and she wanted kind of this autopsy to happen. And to everyone's shock, her vessels were just chock full of these lesions. So you can see just significant medial hypertrophy, these plexiform lesions. Here, this red is something known as proliferating cell nuclear antigen, which is a marker of cellular proliferation of the vasculature. This is smooth muscle actin, this green stuff. And this is normal. This is what it should look like. So this is an insane amount of vascular changes. And so people were like, well, what in the world are these pulmonary vasodilators doing? Because we thought it was kind of anti-proliferative and reversing things. And the thought is that they're really just vasodilating and in some ways just masking these vascular lesions, and that we really aren't addressing the underlying issues that are at hand. And so really our current therapies, which I call the past, are pulmonary vasodilators. And what the therapies that we really need are those that are actually addressing the pulmonary vasculature, that are really remodeling these vessels. Which brings us to BMPR2. So this is the bone morphogenetic protein receptor 2 that I mentioned. It's the most common cause of heritable PAH. About 70% of those who have it have this mutation. And so this signaling in BMPR2 is actually abnormal in those who don't have heritable PAH as well. And so reduced BMPR2 signaling leads to endothelial dysfunction, increased cellular proliferation, and pulmonary vascular remodeling. And so in many ways, BMPR2 is sort of putting the brakes on these cells from growing into these vessels and re-remodeling the vessels. And so there's a drug called Sotatercept, which works in the BMPR2 pathway. And so here you can see that BMPR2, this receptor is anti-proliferative, and it works via the phosphorylated SMAD1, 5, and 8. And then we have the pro-proliferative forces here, which work via the phosphorylated SMAD2 and 3. This leads to increased gremlin and noggin, which lead to these BMPs that block BMPR2 and further reduce anti-proliferation. So you can imagine if you have decreased BMPR2 signaling, there is this imbalance between proliferation and anti-proliferation. So what Sotatercept does is that it binds some of these ligands for this receptor, this activin receptor, and it binds these activins and growth differentiation factors, and basically downregulates this pathway here and prevents these from being upregulated, and basically rebalances proliferation and anti-proliferation. And you think, wow, this mechanism is great, but who cares? Like, does it actually work in patients? And so this is a trial of the phase 3 trial of Sotatercept, the Stellar trial, that was published last year. It's a 24-week randomized placebo-controlled trial of Sotatercept in patients with PAH. It's a subcutaneous once every 21 days shot. And so for those of you who have taken care of PAH patients on remodeling, these continuous pumps, they hate these pumps. They're constantly asking me, when can I get off this pump? Do you have like a vaccine or a shot? And well, this is kind of like a once every 21-day vaccine. And in this study, patients were on marked background therapy. So 96% were on at least dual therapy, 61% were on triple therapy, 40% were on continuous prostacyclin infusions, again, the nuclear weapons of therapy. And so the importance here is that if you're on background therapy, the likelihood that your next drug will work is always lower. So if you show a benefit here, that's important. And in this trial, there is a gargantuan improvement in 6-minute walk. So a 40-meter walk improvement is extremely high after 24 weeks. And there was an 84% reduction of events at 24 weeks. And so people had to kind of like look at this number, like, did they flip it? Is it actually 16%? Like 84% reduction in events at 24 weeks is an insane reduction. And if you look just at PAH-related hospitalizations, and remember, a percentage of these patients, high percentage of these patients on, prostacyclin infusions, in the placebo group, about 4 to 5% were hospitalized for PAH reasons. In the Sotatercept group, 0. Not a single person got hospitalized, which is insane. And so this drug just got approved 3 weeks ago. And so we're extremely excited for this therapy and kind of this new treatment paradigm for these patients with PAH. So in summary, remember this equation. I have this equation tattooed on the fellows' foreheads. They should know this. The PAH and PH are not the same thing. PH is a mean PA pressure greater than 20. PAH is a very specific vasculopathy where you have narrowing of the blood vessels. Be cognizant of the vicious cycle of RV failure. Pulmonary vasodilators are very effective treatments for PAH, group 1. Sotatercept is a new exciting therapy for PAH, and early referral is very important. So thank you very much. Dr. Kraft?
Great talk. Love the last part. The Sotatercept looks really promising. But given that it inhibits TGF-beta, has it been used in other diseases before PAH? Or, because I can see a lot of fibrotic diseases where it may have benefit. But any other past history of that drug?
Yeah, so the drug actually was initially developed for like MDS. And so part of it was, and therefore some of the side effects are related to that. It actually results in an increase in hemoglobin. And so that was the main kind of way the drug was initially developed for kind of bone marrow issues, and then it was found that this kind of change in proliferation. But yeah, it's all kind of in the TGF-beta pathway, and some of the side effects are associated with that, specifically the development of telangiectasia. So that's one of the concerns that we have, is that this was only a 24-week trial. Over time, these patients were developing telangiectasias, which many of them were just cosmetic, which is still important. But we get concerned, obviously, when those telangiectasias form elsewhere, like in the gut. There's a case report of actually a patient who was on Sotatercept and had kind of recurrent GI bleeds, numerous blood transfusions, numerous scopes, many telangiectasias, and it only stopped after Sotatercept was kind of withdrawn. And so then we're concerned, obviously, of telangiectasias elsewhere in the brain, and most importantly, we have the disease of HHT, hereditary hemorrhagic telangiectasias, which also causes PAH, where we're concerned that they may have that kind of phenotype with this drug. So while we're excited about this, long-term data shows that it's still somewhat safe, but longer-term data we might get a little more concerned.
Another question about this. It looked to me like in the Vascular trial, it wasn't pushing, but they were staying the same. Is this concept similar to like the fibrotic, where it's not remodeling, it's improving?
Oh, no, they're definitely getting better. So their pulmonary vascular resistance drops significantly. There's something like a 25–30% reduction in pulmonary vascular resistance, marked improvements in exercise capacity. So it's not, what Jimmy's referring to is in many of the interstitial lung disease, specifically like idiopathic pulmonary fibrosis, our therapies don't reverse the scarring. Our therapies just kind of slow down the progression of that. In this circumstance, it actually is, at least at the beginning, seemingly reversing. But it does bring up the good point of, even if it was just stabilizing it, why are we waiting until their vessels are all mangled before we start it? Why not start it earlier? And so there are studies being done. One is called the Hyperion trial, where newly diagnosed patients are being initiated on this to see if this will help kind of prevent the progression as well. Yeah, I mean, I think it's a dynamic process in terms of these cells. And so if you decrease the proliferative aspect and increase the antiproliferative, then those vessels can seem to, remodel. And honestly, it's analogous to many of you have taken care of patients with cirrhosis who develop portal pulmonary hypertension. In cirrhosis, if you have pulmonary arterial hypertension, we call that portal pulmonary hypertension. Those patients in general cannot undergo liver transplantation because they're too sick and they'll die. However, with pulmonary vasodilators, we can make their hemodynamics improve such that they are candidates for liver transplantation. So they'll be on heavy-duty triple therapy and so on. They get their liver transplantation, and then over time, there's a significant portion of those patients where we can actually wean off their pulmonary vasodilators completely, and they have basically normal kind of hemodynamics. And it's almost like, and their vessels basically just renormalize. And so it's like Sotatercept might be like a liver transplant in some ways, that in some ways it might hopefully be kind of reversing. There are also a host of other additional therapies that are in development that undergo this kind of re-remodeling pathway. Imatinib is one of them, and imatinib offshoots. like seralutinib.
There's a question online. Is Sotatercept, if Sotatercept has antiproliferative effects on arteries, if so, can it be used in reducing atherosclerosis?
Whether it reduces atherosclerosis, I don't know. It would be obviously very interesting. I think one of the hopes would be that if it does have this anti-proliferative aspect, one of our, PAH is a rare disease. Much more common than that is PH secondary to left heart disease, specifically HFpEF. So you have a stiff left heart. And the hope would be like, is it possible that this kind of undoes some of the stiffness of the left heart? That's actually being studied in what's called the Cadence trial, patients with group 2 pulmonary hypertension. Not sure specifically about atherosclerosis, but hopefully in other aspects of the vasculature.
So did that drug work in all the or was there subgroups that
Yeah, so the drug within group 1 PAH, the forest plot was positive for like everything, like every single subgroup. However you sliced and diced it, the drug was significant with respect to the subgroups of PAH. With respect to those who were sicker did better. So those who had higher pulmonary vascular resistance had a more significant improvement. Those who were on more therapies, so it was positive for all groups.
One last question. So, related question is, were they anyone in front, were they genotype or regards to the polymorphism associated?
Yeah, so there were a percentage of patients that had heritable PAH, and I think most of them did have the BMPR2. I don't actually remember. I think it was about the same. It didn't, like, you would think that those who had the mutation would have like the market improvement, but I think it was about the same at least. And it's not as heritable is not as common as some of the other forms. Thank you.